I'm Drew Donaldson, and thank you once again for tuning into the DDT Method podcast. This week, I'm bringing you my interview with Dr. Todd Lee. Todd is a medical doctor, an IFBB pro bodybuilder, and a biochemist. This guy brings so much experience to the table, as well as so much credibility through his extensive credentials. Todd is a no-holds-barred, pull-no-punches type of a guy, and this week we deep dive into some performance-enhancing drugs and how they work. For those of you that like to learn about PEDs, this is the podcast for you. Take some notes, pay attention, and then take some more notes. Because like I said, Todd is about to deep dive into all things performance-enhancing drugs and teach you some things that you didn't know about some common PEDs. Ladies and gentlemen, thank you for tuning into the DDT Method podcast. This week, I'm bringing you Mr. Todd Lee. Now, Todd Lee is coming from a very unique standpoint here, at least in opposition to a lot of the guests that I've had on, because this guy has a medical background and he's a pro bodybuilder. So what we have here is we have somebody that's walking in from both levels. We have clinical application, and we have somebody that's actually been in the trenches doing the dirty work themselves. This guy is a plethora of information, both from the practical application side and from the deep dive into the science side. So today we're going to give you a lot of information on how you can piece together your own course design from a PED supplemental standpoint. And it all starts from the bottom, but it all goes to the top in terms of the information being intermediate to the information being advanced. So we're going to take you on a ride here. We're going to give you some information that hopefully is actionable, that you can deploy and put into your own programs as soon as possible so you can make the most of your progress and you can do it the right way, the safe way, and the effective way. But before we dive into all that, Todd, for anybody that doesn't know you, can you give us a little bit of a background on yourself?
All right. So I'm an IFBB pro bodybuilder and a medical doctor. I don't know of others that can claim the same, but I'm also a biochemist. And I know I'm the only person who is all three of those things. So that's why I speak with authority when I talk about PEDs, is that often you'll hear people say on the internet, if somebody is adamant that there's only one way and their way is the only way, then you know they're a charlatan. That would be the case if the person had no education and had no credentials. But if I do have those two things, this is why I speak with authority and say, do it this way, don't do it any other way. And it's not because there aren't nuances or outliers. It's just I'm a very black and white person in how I speak, because I assume incorrectly that everyone knows there's outliers and that the general rule of thumb doesn't apply to everyone all the time. But if you say that with every sentence, it's tedious, it's exhausting, it's stupid. That there are two-headed snakes. That doesn't mean that snakes have two heads. It means that once in a million, there's a snake born with two heads. So that it's not worth talking about two-headed snakes in every conversation about snakes as if it's 50% of the snake population. That's ridiculous. So when I say things like DECAs and 19 NORs are dangerous for gynecomastia, there are going to be a million people in the comment section that have this very ignorant point of view that their personal experience is the norm. And they'll say, that's not true. I use 19 NORs and I don't have DECA. I don't have gyno. So that's not true. This guy's an idiot. He calls himself a doctor. It's that there's no advantage to using those drugs. And you've got the potential disadvantage of getting gyno, that unless you want gyno, don't do it. It's not like it's a 1% chance or a 2% chance. It's like a 40, 50% chance for any given person they're going to get gyno, depending on how much testosterone they're using and other factors. So that's why I'll make a blanket statement, just stay away from this class of drugs. Because if I'm talking to beginners and I'm talking to intermediate people, that's what I mean. That if somebody's already an advanced person, they've used every drug and they know exactly how every drug works in their bodies, why the F are they watching this episode? Why do they want to learn if they already know everything? So I'm talking as if the person who's watching this doesn't think they know everything. And so therefore, I will give very clear guidelines on how to exactly navigate so you get the best results the safest way possible without almost any possibility of calamity. And that people never listen. They always want to push the boundaries and they always get burned. And then after they do that enough time, they'll be like, you know what, maybe I'll stay on the straight and narrow and not get hurt from now on. And hopefully we can cut through this shit. And then that's why I'm doing this first, is to explain, like, people are going to get really mad because I'm so black and white. And it's because out of the hundreds and hundreds and hundreds of people I've worked with, this is the stuff that nobody gets hurt.
So let me break this down a little bit for anybody that's only kind of half paying attention. What we have here is the complete opposite of probably 85% of the information that you're going to find when you look up any information on anabolics on YouTube, because 9 out of 10 times you're getting somebody that's just watched a bunch of other YouTube videos, or maybe they've done it a few times themselves, and they're speaking in absolutes about situations, like Todd said, are based on either personal experience or just anecdotal evidence that they've watched through the eyes of other people. What we have here is hundreds of case studies in practical experience, along with his own experience, along with the credentials that he just listed. So this is going to be a crash course in how to do things the right way. So before we get into actually building out the cycle, when you're, let's say, intermediate level, you've run some gear before, you're beyond that, I've done a couple cycles of testosterone, I know how I react to it level. Before you even start, what are some things to consider? Are we getting blood work? Are we checking health metrics? What are we checking? What are we doing? What's our checklist before we get rolling?
No matter what someone's expertise level in their head is when they come to me, I'm treating it as if they're a kindergartner who thinks he's president of the United States. Because when someone tells me how many cc's they use, they're demoted to the bottom of the barrel. That if they measure drugs by the cc, as far as I'm concerned, they have a 0 in the class. That's their grade. It's not an F. It's not 50. There is 0. That if they don't know that drugs are measured by mass and they're giving me a volume, irregardless of concentration, there's a serious flaw in knowledge or intelligence that needs to be addressed. And this sounds condescending. I am going to sound condescending. I am on the spectrum and I can't look down without being clearly looking down. I can look laterally and be respectful. I can look up and be respectful. But if I have to look down to someone and I have to bring it down to their level, it's going to be very obvious that I'm talking down, because that's what I'm doing. And I'm not a deceptive person. I haven't learned how to be fake and polite, because to me, manners often are just deception. So if I'm going to be credible in what I'm saying, I have to be credible in all things. I can't lie in some parts of my life and tell the truth in others. I have to tell the truth across the board, be completely devoid of deception. So if I like you, you know I like you. If I respect you, you know I respect you. If I don't like you, you're going to know I don't like you. And if I don't respect you, you're going to know I don't respect you. I'll still help you, though. That I still see it as my responsibility to help everybody. So first thing I want to do is I want to look at their blood work. And that's what I want to see is, I want to know their use history, but mostly I want to see their blood work. And what I look at is this person a candidate for using HRT? Because HRT is level 1. So what's their testosterone? What's their DHT? What's their estradiol? What's their IGF-1? These are our outputs. So the drugs are the inputs into the system, and then the outputs are the testosterone, DHT, estradiol, and IGF-1. This is how I determine what kind of effects we're going to get. If drugs don't feed into the system, they're not very useful drugs. Now, in so far as health markers, I don't care about what Mr. Magoo, the primary care doctor, cares about. I care about higher order thinking. So I care about cystatin C for kidneys, because creatinine is not useful in our population. We have too much muscle. It's going to be elevated, especially if you train to failure. If you train to failure, you're going to have elevated creatinine. ALT-AST, to me, that's a measurement of volume of your training, because the ALT-AST, people say they're liver enzymes. They're not fucking liver enzymes. Again, bottom of the, you back to the class. You immediately get, you're like, remember there's a board game where it's called Head of the Class, and if you got a wrong answer, the commercial was the kid got sent to the back of the class, and like his desk was dragged into the back of the class. As soon as someone fucking calls them liver enzymes, back of the class. That you don't know shit. They're not liver enzymes. I don't care what Mr. Magoo doctor told you. They're aspartamine and alanine transaminases. They convert amino acids to glucose. That happens in the liver. That happens in the muscle. So if you're using your muscles a fuck ton, those enzymes are going to need to upregulate if you're a low carb dieter. If you're rupturing muscle cells, shit in the muscle cells is going to leak into the bloodstream. So the AST, ALT, and creatinine are go up. So that doesn't mean your kidneys are failing. It doesn't mean your liver is failing. It means what it means. It means you've got more of this in the blood, and you can't draw any more conclusions. Correlation isn't causality. So we look at GGT. GGTs are more specific for the liver. So if we got GGT and ALT and AST, it's probably the liver. We got AST and ALT, but no GGT, it's probably you're doing too much volume. If you got GGT and no AST and ALT, it might be widespread inflammation. I'm going to look for CRP. I'm going to look at the cystatin C. So if your cystatin C is elevated or GGT is elevated, but your ALT, AST, and creatinine are normal, well, that might just be inflammation. It's not your liver and the kidneys because you don't have both markers for kidneys or both markers for livers present. If people are lost in this, that's okay. I've never met a fucking nephrologist who knew what cystatin C was. I don't know hepatologists who know what GGT is. So it's okay if you don't know what I'm talking about. The head of the university's department doesn't know what this shit is, and most of the time. The only people who know what this is are people like John Jewett or Broderick Chavez. All right. And so like the goats of PED educators. So I look at ApoB for cholesterol and LDL. A lot of people are hung up on HDL. HDL being low can make, doesn't necessarily, but can make LDL high. But it's the LDL that does the damage because it's what forms foam cells and causes atherosclerosis. But atherosclerosis only occurs in the presence of inflammation and high blood pressure. So if you don't have high blood pressure and you don't have widespread chronic inflammation, having an LDL isn't necessarily bad. So drugs that could drive down HDL temporarily, if they're not concomitantly increasing your LDL and you don't have a high ApoB and you don't have blood pressure issues and you don't have widespread inflammation, we don't have to worry about atherosclerosis that much. Of course, you can get a calcium score to check, as I would if someone had like multiple risk factors and were the appropriate age. But for an intermediate or beginner bodybuilder, this is not something that I think is a concern.
Now, really quickly, to kind of break that down a little bit so people can begin to understand it, and correct me if I'm wrong. So what we're looking out for is the presence of inflammation, which would imply that the inner arterial walls are inflamed in the presence of high LDL, in the presence of high blood pressure, which drives further interarterial inflammation. The LDL is driven to that inflammation to almost try to correct the problem. It's trying to go in and like spackle the walls, but it's not actual damage. It's inflammation caused by systemic inflammation and high blood pressure. So we're basically spackling nothing until that artery begins to close. That's essentially the process.
So what it is the high blood pressure is slamming into the wall. Eventually, if there's inflammation, there'll be cracks in the wall. The LDL comes in and tries to seal up those cracks. The problem is sometimes it gets caught inside the cracks, and then platelets will form blood clots over those plaques. Eventually, those plaques can completely block the artery and cause a heart attack if it's an LDA, like a widowmaker artery, right? But worse, we saw a lot of deaths in 2021 and 2022, specifically because there was some certain intervention that was forced upon people at gunpoint, and that intervention increased clotting. Now, anabolics also increase. People believe anabolics increase clotting because of higher hemoglobin, higher hematocrit. This is not entirely true. We can get to that in a moment, but let's pretend it is true. When you add the combination of being exposed to a panacea that wasn't a panacea, that is increasing the clotting, you've got drugs you're already taking for bodybuilding that increases the clotting, then you go on a flight and keep your legs low, then you're going to get clots. Those clots get thrown. They end up as a pulmonary embolism, and then you die from a heart attack, especially if you're already asleep. So that's why all those guys were dying of pulmonary embolism. And because they didn't want to add them to a lawsuit that hasn't happened yet, but most certainly will, that's why their autopsies weren't released to the public. Because the amount of those that seemed to only be happening to athletes was astronomical. That athlete cause of death went up 70-fold in 2021 and 2022. And so in the bodybuilding community, for some reason, people just thought it was just bodybuilders and falsely attributed it to anabolics. And although those are a correlated a fact that added to it, it isn't what actually was the problem, because people have been using anabolics for decades before and for half of a decade since, and we haven't seen the same rash of deaths. So what we get with this back full circle with atherosclerosis and the plaque formation, you can throw those plaques, and those throwing the plaque can be either a stroke if it's on one side of the heart, going away from the heart to the body. Those plaques, when they get thrown, that might cause a stroke. A stroke is basically just baby talk for a brain attack. It's an ischemic cerebral attack, or it could, infarction, or it could be cerebral hemorrhage, if that's another form of stroke. So there's hemorrhagic stroke and a normal ischemic infarct. So a heart attack is an ischemic infarct of the heart. A stroke is usually an ischemic infarct of the brain. And that's usually caused by throwing a clot, because you could have a big artery that throws a big clot, and that big clot travels and eventually gets to a small artery and plugs it. So if something is on your aorta and it breaks loose and gets stuck in your carotid artery, it can shut off blood flow to the brain. Now, we have multiple methods of driving blood to the brain, but there's one circle around the hippocampus and a hypothalamus. It's more about the hypothalamus, called the circle of Willets, where it actually is like a ring of one artery that feeds out into all other parts of the brain. If that gets clogged in the middle of it, it really can fuck shit up. So I know we're supposed to be talking about steroids and I'm talking about cerebral infarcts, but the point is people have really hung up on the wrong details. In the end, if you want to live, you keep your blood pressure under control. Because if your blood pressure is under control, we won't destroy the kidneys. If we don't destroy the kidneys, we won't have high blood pressure. And so that's why so many people are pushing the telmisartan as a prophylactic for all anabolic use, because it cuts down on water retention, it cuts down on kidney damage, it decreases blood pressure. It also is going to allow for left ventricular remodeling, so that your heart, if you don't have an athlete's hypertrophic left ventricle, if you have a non-functional hypertrophic left ventricle due to high blood pressure, it should improve that as well. So that's why telmisartan is a great prophylactic to have. Now, of course, if it drives you into a negative blood pressure state, like you're 100/60 and you get lightheaded standing up, then telmisartan may not be right for you. But most guys who are intermediate or over 40, they're going to be above 120 or above 80. A little bit of telmisartan, like 20, 40 milligrams, would be a great way to mitigate any blood pressure problems. Because once again, if we keep the blood pressure down, your cholesterol doesn't really matter. Your LDL doesn't really matter. Now, people are going to flip the fuck out because they're going to give me, well, my uncle, blah, 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 blah. And they're going to tell me all the comments are going to be littered with anecdotes. But those anecdotes, if you watch, and this video gets, let's say, 1,000 views, and you have 3 people saying I'm wrong, that means I was right 99.7% of the time. Right? Everyone who disagrees is going to run their mouth. So it's not an indicator of the population as a whole, the loud vocal minority. The case in point, CNN thought they were going to win the election. They were fucking wrong. So just because the people who scream the loudest do not represent the whole population in any respect. It's usually the outliers are running around to every video and saying their opinion in every comment. And then it gets misperceived as being an actual possibility.
Now, people are just more inclined to want to argue or fight about something than they are to take the time to write out, yes, I agree 100%. So I'm right there with you on that one. Now, in terms of telmisartan or really any ARB as a prophylactic deployment, would you say that that's something that should be highly considered by any bodybuilder or anybody using PEDs, especially as they get up there in age? Because I'm 40 years old. I've been using it at 40 milligrams for 3 years now, and it's spectacular. It keeps everything right where it needs to be. I've noticed I'm a little bit leaner as a baseline. To me, it's amazing. I love it. But is it something that you think the majority of men, particularly, especially getting up there around 40, should be looking into?
I think that if you have high blood pressure, it's the first line treatment for our population. So rather than, there's an ACE inhibitor that starts with an L that I'm drawing a blank right now. And then there's an ARB that starts with an L. And so the insurance companies won't cover the ARB, but they'll cover the shitty one, lisinopril. They'll cover lisinopril because it's garbage and 40% of people get a cough. If you get the cough, then the schedule then changes so that now the doctor can prescribe losartan. And then you're never going to get approved for telmisartan because it's $300 a month if you go through the US system. Now, if you were to go through back channels and get it on the black market, it's $40 for the year. And it's 100 times better than all the other meds. And it's not like it's bad meds. You're just ordering it from another country. And other countries aren't this extremely bizarre for-profit model that the United States has with placement companies that drive up the price of pharmaceuticals. Because the pharmaceutical company doesn't get it. The insurance companies make the placement companies drive the price up so that the only way you can afford medicine is with insurance so that everyone has to pay for the insurance.
Mm-hmm. That's generally how it goes. I do recommend in most cases people at least ask, because in some cases I have seen it covered. Mine's covered by my insurance, but I'm in Florida. It's like the Wild West down here.
Right.
So it's one of those things where it's definitely worth looking into. As far as other health metrics, are you looking at things like heart rate variability? Are you looking at resting heart rate? What else are you checking?
I mean, resting heart rate matters. That if you're doing fasted cardio, it should go down. Heart rate variability is supposed to matter for recovery from endurance sports, not necessarily for bodybuilding. Now, maybe I'm wrong, but that's what I've heard, that the heart rate variability was measured in non-correlated sports to bodybuilding.
Mm-hmm. Generally more of an endurance marker, right? But they're looking at it now as general longevity, but I think the jury's still out on that, but not essential for what we're doing.
As usual, I hate how they take correlation and they attribute causality, which is stupid. That the reason why these people with low heart rate variabilities live longer is because they're doing fucking cardio. That's why, is because of all the benefits of the cardio. It's not arbitrarily the low heart rate. If you took a pill that lowered your heart rate, like a beta blocker, that's not necessarily going to make you live longer. It's that they do the cardio, and the two benefits are lower heart rate and greater longevity and decreased morbidity, mortality. That it's not a causality from the the HRV to the longer health span and longer lifespan. So that's one of my pet peeves is when people do false correlations when they attribute causality to a correlation.
Right. It's the same as the people that speak in absolutes about everything. They hear one thing and they just say, this is how it is forever.
Well, I speak in absolutes because I know that if I'm talking between the negative 2Z score and the positive 2Z score, and that attributes for 95% of the population, and I'm talking to thousands of people, I will do the most good in the shortest amount of time by speaking to that 95%. If it takes an equal amount of time to address the bottom 2.5 and the top 2.5, that means I can cover a third of the material in an hour. That if I could just cut through this shit and just address the middle 95%. But when I have someone who does a consult with me, then if they are in the bottom 2.5% or they are in the top 2.5%, my treatment plan will be specific for those people. That's the only time. Like, it's not like the consults are some secrets. It's just the consults will be tailored to the individual, and the individual might actually be an outlier and require the nuance that isn't covered in the videos.
Right. It's like you were saying before, there's information for the masses and there's information for the specific. We all do have these small general differences, and some of us have gigantic differences. But again, we can't speak strictly to that one person, because that would be a disservice to the rest of everybody else.
Right.
Now, as we move forward in this process, we're getting this diagnostic testing, we're looking at blood work, we're looking for these markers. Is there anything else that you're looking at as kind of a be all end all? We need to check this, we need to have this in line before we start building your course?
Those are the big ones that jump off my head. I mean, I think it's 137 things on my blood test that I run, and I get it for very cheap. It's like $550, whereas if you order it yourself, it's like $2,500. So it's people save a lot of money by going through me, because when they go to their normal doctor and try to get their insurance to cover it, they always fuck it up. Instead of free T3, they order like T3 total or T3 uptake. They don't order reverse T3. They just don't do anything right. Even the specialists, you could go to a thyroid specialist, endocrinologist, still don't order reverse T3. So you have no idea what's going on. It's incredible how bad they are at their jobs. But, I mean, that's the thing with women. I focus on other stuff. I want them to go in on the 5th day of their cycle. I want to look at their estradiol, the progesterone, the pregnenolone, all the stuff. I do that for men too, but it's not relevant for men as it is for women. LH, FSH, to see what their body's making, their testosterone, the DHT, of course, their IGF-1, of course. It's a little bit more complicated. It's a lot of bit more complicated for women, but I also look at their thyroid as well, because I want to disabuse them of the false belief that everything is their thyroid's fault, because that's what they want to believe. The doctors will order a TSH. The TSH is high. They give them thyroid meds. They give them the wrong thyroid meds too. They give them the T4 without checking the reverse T3, and the T4 just converts into more reverse T3. The T3 active stays low. They don't lose anything. And now they're stuck on thyroid medication for life, the thyroid medication that's not doing shit. And then none of these guys, they do dual treatment with the Synthroid and the Cytomel. They don't do the T4 and the T3 balance of the drug so that you have both. They won't do the T3 because it'll shut off T4, but they do T4, but it doesn't convert to the T3. You kind of have to do both, but they don't want to do both because polypharmacy is over their heads, even though they're the specialist in that field. That doesn't make any sense. What
are your thoughts on the glandulars in that world, like the nature thyroids, the Armour thyroids? Are those efficacious because they have both in them?
The thing is you can't okay, so that makes sense on paper if you don't know what you're doing, right? Combination drugs are great for people who aren't smart enough to do the science and the math. I'm talking about the doctors, but I don't ever advocate using combination drugs because the absorption is different. Like T4 absorbs differently than T3 and has a different half-life. So you would be dosing them differently. Additionally, they come prepackaged with this much T4 and this much T3. That balance may not be optimal for someone else. Like I, for one, do better on 150 T4 and 12.5 T3 in prep. They don't make one like that. That's a nonsense conversion. It's usually a 2-to-1 ratio. For you to be on 150 and or it's either a 2-to-1 or something like that ratio where it'd be 125. You wouldn't get 150 and 12.5. That's not possible. You'd never see it. Plus, I don't like to do 25 in the morning. 12 in the morning. I like to do 6 in the morning and 6 in the afternoon for my T3. My T4, it doesn't matter when I take it. But I have to take it liquid because if I take it oral, it doesn't get absorbed. I've never met another doctor who actually understands the thyroid like that. Not saying that there aren't coaches who understand it like that. There are a lot of good coaches out there. There are not a lot of good doctors out there. They're not going to fine-tune someone's hormones that close because they don't have results-driven mindset. They have a I don't want to get sued mindset. So they want to do what's within the little box that their little American College of Endocrinology says they're allowed to do. And if they step outside the box, they're open to a malpractice lawsuit. And they care more about themselves than they do about their patients, so they won't take any chances. With a coach, it's the Wild West. The coach is going to tell the athlete what's best for winning the show. The problem is the coach may not give a fuck what happens to the patient or the client after the show. So I'm aware of the box. I know when I'm stepping outside the box. And I often step outside the box because I think outside the box. But I also have a results-driven mindset, but I prioritize the patient's health over winning because you can, live to fight another day. You don't want to win the battle, but lose the war.
Right. So it's that big picture mindset.
Yeah. Anyone who's had a wife knows that you can't win every argument because you'll destroy the marriage. You have to let her win the unimportant argument so that you can win the important arguments and keep your life on track and also keep the marriage together.
So let's say everything's checking out where we want it to be. We have some numbers that are not problematic, but they're telling us what's going on. And again, we have an intermediate person. Maybe they've done a show or two before. They've run a few cycles. What are you looking at to determine what column we're going into beyond your testosterone base? We know we have to have a testosterone base there, but what direction are we go? Why would I go 19 NOR? Why would I go DHT? Why would I go both?
So one, we don't always need a testosterone base, but that's a nuance not worth addressing because that's not the 95, right? So that I do have a video about nandrolone only and how to effectively navigate it, but we're going to stick to the vanilla today. So the vanilla procedure is start HRT. And HRT, I usually start people on 20 milligrams of testosterone a day and 2 units of GH. So that's right. GH is drug number 2. Drug number 1 is testosterone. GH is drug number 2. This is contrary to what most people do. They usually don't introduce GH until after. It's way too late and you miss the boat on it. So if someone's close to 40, 2 units of GH a day. If someone's 20, there's no point in 2 units of GH a day. Your body already makes 2 units. If you're going to use it, you got to use 4, 6, 8, etc. But for someone who's over 40, 2 units is still going to be dramatic because we're going to slow the aging. Now, a lot of people get butt sore about this because they're going to say there's studies that show a decreased lifespan, blah, blah, blah. So aging can be 2 different variables. There's longevity and vitality. So there's lifespan and there's health span. So I don't want to even argue about longevity or lifespan. There's no evidence that it shortens it. People have deduced that IGF-1 shortens lifespan in rats, and they've confabulated that with GH shortens lifespan in humans. It's wrong patient population, wrong fucking species, wrong compound. So I'm not even going to entertain that one. Those people are fools. But there is a lot of outcome data with humans showing they have increased vitality. Their health span is increased. That people in their 80s have more strength, fall and break their hips less. And as you know, old people, if they break their hip, they usually get pneumonia in the hospital and die. A broken hip is a death sentence for most elderly people. And so the number one way to keep your grandma or grandmother alive is to have them physically fit enough to not fall and break their hip. And so also it helps with Alzheimer's. So in order to keep your grandma and grandpa actually grandma and grandpa rather than just a baby with wrinkly skin, then you also could benefit from GH. And then of course it helps everyone down the line. But I'm going to the extreme of the example saying that if someone starts GH at 40 and stays on GH their whole life, we don't know how young they're going to be when they're 80. The only person we have an example of someone like that is Sly Stallone. And Sly Stallone at 78 looks better than most guys do at 40, certainly from the neck down. And in Rocky 6 is a perfect example of that he looked like a fucking tank in Rocky 6 or Rambo 4. And he was like 68 years old at that time. And he looked way more physically fit than almost anybody who's 30 who's not on gear. So I'm a big fan of GH. GH should go in. I got plenty of videos about GH. 2 units, that's your base, right? Now, this is what I do. I do prospective serial blood work to dial in the test and the GH first. The goal of the testosterone, this isn't all it does, but the main reason I use it is it's a pro-hormone to estradiol. And the estradiol through the estrogen beta receptor will upregulate the GH to IGF-1 conversion. And that's systemically and in the muscle. We can't measure the muscle's IGF-1, but we can use systemic IGF-1 as a proxy for muscular IGF-1. So if we double the IGF-1 in the blood, we have to assume the IGF-1 in the muscle went up approximately as much. So we basically titrate up on the testosterone. So 10 milligrams a day more every 2 to 3 weeks. Right? Well, let's do it every month, because if we're going to do the blood work every month to make sure that it takes about 4 weeks, if it's cypionate or an athate, the half-life's approximately 7 days. You wait about 4 half-lives to see if we've had an elevated level to the new level. So if we go from 20 to 30, it's going to take 4 weeks for the blood and the body to look like you're on 30. That's when we test it. If you have no symptoms of high blood pressure or nipple sensitivity, and you don't have like a moon face or peripheral edema, then we can handle more estrogen. And then we do more, 10 more. Then we find the upper limit on estrogen. Now, maybe 60 is okay in you and 30 makes someone else have tender nipples. That means that 60 is okay in you and 30 is not okay in them. Maybe 20 milligrams of testosterone in you gives you a 50 estradiol, but 100 milligrams of testosterone in someone else, they're only at a 30 estradiol. That's okay. People are different. And that's why the blood work's necessary. That's why people want a cycle. I can't give you a cycle because I don't know anything about how your body's going to respond to these drugs. That's why this idiotic mindset that people start on 500 tests and they're like, oh, everyone's first cycle is 500 tests. That is the dumbest fucking thing I've ever heard. That is so stupid. Not everyone needs the same amount of drug. It makes no sense at all.
Well, they're doing this and they're making these blanket statements about estrogen in the meantime, too. That's why it seems everybody's starting everybody on a bunch of aromatase inhibitors and they're demonizing estrogen, even to this day when we know better. We know about the cardioprotective benefits. We know about the neuroprotective benefits. We know how it ties in with IGF. Yet, left and right, there's still people throwing around Arimidex like they're Skittles and tanking estrogen levels. How important, just so we can throw it out there right now, how important is estrogen to just general health?
Well, that's why test is the test base. Test is the pro-hormone to estrogen. If we didn't need estrogen, we wouldn't take testosterone in the first place. We would skip right to shit like Primo, Masteron, DHB, and we would never use anything else. Or maybe Tren. We would never use testosterone if it wasn't for the estrogen. It has no other advantages except for that it provides estrogen. So it's so ludicrous that these HRT clinics, they're such shitbags that they prescribe half a cc a test and one Arimidex or half an Arimidex every 3 days. And it's $200 a month. Every motherfucker that comes in gets this Happy Meal of a half a cc a test and a half of an Arimidex every 3 days. None of them have any fucking idea what they're doing. They're running the bare minimum blood work that isn't even right just so they can legally cover their ass. They have no ethics. They don't give a fuck about the patients. They're all fucking scumbags. Not every clinic's like this, but the ones that start with T seem to always do this shit. Yeah. That they're just total scumbags. I know that the place I work with, Fusion, since I'm the one who's doing it, that's not the case. And I know I trust other people. Like I trust DJ with M&M Labs. I know she wouldn't do something like that. I believe like there's other people out there that I trust and can do a good job, but it's amazing how fucking unethical these people are because they're not doctors. There is a doctor somewhere who signs the script, but he has nothing to do with the actual business. And it's such a disrespect to MDs like me that there's these clinics actually operating like that because it makes all of us look bad. Just like all the endocrinologists who order the wrong test make me look bad. It's very disappointing. It's almost like people hate MDs because so many MDs are terrible now. It's like how people think of priest, they think of pedophile. Whereas 40 years ago, it wasn't like that. People respected priests, but it just was a handful of these priests and the fact that the church supposedly covered it up, that now no one trusts organized religion. No one trusts priests. Now everyone's going to therapists, not their priests, to discuss their problems. And now it's for profit and they're getting hit with a bunch of medications that are also unethical. It's just like, the world's a really dark place through my eyes, and we're not going to go there any further. We're going to go back to the topic at hand. So the estrogen is a cofactor. It's a cofactor for the GH to IGF-1 conversion. Now, the IGF-1 works on its own pathways to grow muscle. And I don't know if you want to go into the biochemistry of muscle protein synthesis. I know that
let's do it.
Okay, so the androgen receptor will go down to an androgen response element, I believe, or binds to the nuclear binding domain, binds to the DNA, and it goes into transcription. transcription, then translation, then muscle protein synthesis. So I kind of made it confusing. There's an androgen receptor inside the cell, a cytosolic androgen receptor. And when testosterone or any anabolic steroid binds to this receptor, it then migrates to the nucleolus and it does some stuff. And it basically, out of the ribosome, pumps out new muscle protein. And that muscle protein is the active myosin filaments that do the cross bridging and the contraction. And that's what ties into stuff like Kassam and all the other guests you've had on that probably talked about 2X fibers and calcium fatigue and all that complicated biochemistry of physiology. This end of it actually is all contiguous, but I'm going to stick to my domain here, which is the endocrinology. So the IGF-1 pathway works in a different way, that they feed into each other. The androgens will upregulate the GH receptors in some ways. Like, for example, it'll cut down on myostatin and somatostatin. So like the estrogen alpha receptor, when it binds estrogen, will release somatostatin to block the GH receptor. But the testosterone, when given with the estrogen, blocks that somatostatin. So it actually amplifies the GH receptor. So when GH binds the GH receptor, which is on the surface of the cell, it's not inside the cell, because remember, steroid hormones are fat soluble and peptide hormones are water soluble. So steroid receptors are inside the cell and peptide receptors are on the surface of the cell. So insulin and GH bind to the surface of the cell. The steroids that actually grow muscle bind inside the cell. There's also surface androgen receptors as well, which are called non-genomic action. And that's where a lot of the orals and DHT, not DHT derivatives, but DHT actually binds. And they have facilitative roles to help this process. But we're going to keep it a little simple and focus on just this. The IGF-1 has other functions. So the IGF-1 also helps with muscle protein synthesis, but estrogen beta is a cofactor for converting the GH into IGF-1. So when estrogen binds to estrogen beta, it's an up switch to muscle protein synthesis. When estrogen alpha is bound, it's a down switch in the way that it can have myostatin or somatostatin inhibit the GH receptor. Now, in the other ways, estrogen receptor alpha is helpful. One, it's supposed to upregulate insulin sensitivity on the cell. Two, it's supposed to bind to the satellite cells, and they're supposed to donate a nucleus. So the more nucleuses inside the cell, the faster it can generate more muscle protein. So all these guys, they want to take more and more and more and more steroids, but the machinery can only move so fast, and the speed of the machinery moves is contingent on how many nucleuses are in each muscle cell. But it's the IGF-1 and estrogen that upregulates the amount of nucleuses. So using androgens would be like, let's say you get some day workers and you want to build a house. It's the estrogen and the IGF-1 that determine how many day workers you have. The androgens are just how many bricks and lumber you have. So they can only work so fast based off of how many nucleuses are there. So more androgens is not necessarily the answer.
So utilizing these different pathways, you're literally supplying the workers and the supplies to work in unison. You're not just overloading one pathway.
Right.
And what we have here is why you're choosing the testosterone with the GH.
Right.
You have this giant interplay between the testosterone and the GH, but also the estrogen that's being converted from the testosterone and the IGF. So everything is basically hammering the cell from every angle.
Right. Now, a lot of people want to use insulin. We're not going to get to insulin yet. Simply put, insulin is something you introduce when you become insulin resistant. There's a false belief that there's a guaranteed effect of GH is insulin resistance. This isn't true. That if you abuse GH and you have disordered eating, you may have insulin resistance, but then the proper treatment isn't using insulin. We have better drugs now like retatrutide that would, if they're actually do what they're supposed to do and what the evidence shows, they would help sensitize. So berberine, retatrutide, Stan Efferding's 10-minute walks. All of these things would improve insulin sensitivity. So the treatment for insulin resistance is fighting insulin resistance. It's not just slamming the insulin receptor with more insulin, because the more insulin you hit the receptor with, the more intramuscular fat is accumulated. And it's the intramuscular fat that causes more insulin resistance. So treating insulin resistance with insulin makes you need more insulin.
So correct me if I'm wrong on the GH and its potential for increasing that insulin resistance. That's due to the fact that GH inherently is glycogen sparing, which is going to keep your blood sugar a little bit higher. But that's only going to be a problem if that's not being cleared out or utilized. Right. So essentially, if you take a bunch of GH and just sit on the couch and don't do anything and eat a shitload of carbohydrates, then we can potentially walk into that world. But why the fuck are you doing that to begin with? If we're actually utilizing really any of these multiple steps that we have to clear out that blood sugar, and that being why retatrutide would be a possible example, because that's increasing insulin sensitivity, the GIP glucagon pathway, and pushing everything through and thus clearing it in and of itself. It's like a continuous motion thing. And then even like you said, the 10-minute walks, even that in and of itself is clearing that blood sugar. So all we need to do to really mitigate this insulin resistant fear from GH is essentially move and clear it until you get into that N of 1 situation or just extreme GH abuse.
The whole point of the insulin, it does a few things, but the main thing it does is it causes GLUT4 transporters to migrate to the surface of the cell on muscle. There's other things that do that. So the GLP-1s will upregulate the beta cells in the pancreas producing endogenous insulin. So we won't run into pancreatic insufficiency from having too much carbohydrates using those. Do they actually help with sensitization of the insulin receptor or GLUT4 transporter migration? Maybe not, but RALA does, cinnamon does, and so does vandyl sulfate, works in the liver, which is a complicated side step, but chromium picolinate does. That's why I put those in my intra-workout drink with HCBDs, Battle Mead. That way, when somebody trains, I open up all the muscle cells to receive the carbohydrates. So I've never had insulin resistance from using GH. I was running as much as 20 to 25 units a day, and I was still waking up with 80 blood sugar without insulin. Now, after prep, I fucked myself up. And so I've had diabetes since then, and I've been treating that. But prior to all that, it wasn't the GH doing it. It wasn't the GH that was causing insulin resistance. So I've never seen it in any of my people where they're using HRT doses of GH or even 8 units, 10 units of GH where they actually needed insulin. In 15 years of coaching, I've never had to use insulin on somebody because I've never had somebody who had bad insulin sensitivity. I've never had someone insulin resistant. So therefore, the whole concept in the bodybuilding community, the people who say this, it's always this conversation. I talked to some big guy at the gym, and he said that if I use insulin with my GH, I'll get even bigger. And that's what he did. I was like, okay, is he big? Yeah, he's huge. I was like, is he soft? Well, he's not as hard as you, but shut up. Is he soft? Could he win? Could he step on stage and win? Well, he doesn't compete. Of course he doesn't. Is he covered in pimples? Yes. Is he bald? Yes. I was like, so you've got some grimace, because I'm sure he's purple too. So you've got like pimply grimace is telling you what to do. Do you want to look like a purpley grimace? And they're like, no. I'm like, why the fuck are you listening to purpley grimace? Did he tell you to go buy some burgers from Hamburglar? No. I was like, well, this ass clown Ronald McDonald motherfucker needs to keep his mouth shut because he don't know what he's talking about. And that's why he looks like grimace. So ask yourself, before you use insulin, is the person telling you to use insulin, are they a grimace? Are they purple, bald, soft? Then don't fucking listen to them because that's what it looks like when somebody relies on drugs and not science.
So at what point do we look into deploying it?
Never. Like I've never had to use it. Like in myself, I use it because I actually have diabetes. But unless you've given yourself diabetes, either you have pancreatic insufficiency or insulin resistance, you don't use insulin. And even if you do, you get a continuous glucose monitor, and you use the continuous glucose monitor to determine how and when you use the insulin, whether it's Lantus in the morning, whether it's Humalog pre-training or post-training, whether it's Humalog with certain meals. It's just a very complicated thing that doctors can't figure out. And so unless you're smarter than a doctor, you're probably not going to be able to handle it. And it's not easy to manage, even for someone who is used to giving themselves 10 shots a day. It's still a pain in the ass to stay on top of it. Let's see, I've got my CGM right here. I have, on my second day of retatrutide, I have dropped insulin from my body. And this is my, I don't know if you can see it. Shit. No, you can't see it, can you?
Huh. A little bit of a glare, yeah.
I don't know how to turn down the brightness, but nope. Anyway, so it's 119 is my average right now. Mm-hmm. And then my 3-day average is 116. Then it was 121 before. So, I mean, the graph is never going above 140 since I introduced retatrutide, where it was mostly up to 180 when I was using insulin and not retatrutide. I've only been on retatrutide for 1 day. Now, that's not me endorsing retatrutide. Maybe there's some downsides. It's not even available to the public yet. It's only available on the gray market. But that's how opposed I am to using insulin, that I'm willing to try something experimental and theoretically dangerous because of, and that's how much more effective it is, because all it's doing is it's correcting the real problem rather than leveraging it as an anabolic. And even if you leverage it as an anabolic, it's still going to result in intramuscular triglyceride accumulation, which is going to end up driving up the insulin resistance. We want to drive down insulin resistance, not drive up insulin resistance. Scientific Snitch, I did a podcast about this, that we talk in depth about mTOR. We have an episode about bulking being dead, and we have an episode about insulin sensitivity. And if people want, check those out, because she goes into it in much more detail than me and makes much more sense than I do. But back to the steroid thing. So once someone's already maxed out their estrogen, they can't handle anymore, wherever that happens to be, where they're starting to get a little bit sensitive nipples or blood pressure increase or peripheral edema, or they just look puffy and they don't like it, we roll back. We don't add an AI. We don't add Primo. We don't add EQ. We roll back to the testosterone that's safe. And now we start pushing up the GH. Now that we've got the maximum amplifier on the GH, since the GH is more expensive than the test, we do the test first. Then we start driving up the GH. And at some point, the IGF-1 will keep going up, 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 and then it'll stop going up. That's when you're using unnecessary amounts of GH. Now, there's anabolic and metabolic effects from GH. The anabolic effect is through IGF-1. The metabolic effect of GH is due to the fragment 176191, which has been renamed AOD. It's expensive to use this for an AOD. So rather, if you really wanted increased fat burning, once you've maxed out your GH for the IGF-1 conversion, instead of using more GH to burn fat, the intelligent thing to do, if you're in a fat burning calorie deficit, if we're actually cutting, you would use AOD instead to go over that limit and use more. But because it's also not going to have the same water retention of the GH. So we want to use, so let's say we maxed out at 50 testosterone a day and 8 units of GH a day. If you use more than 50 tests, you're going to have sensitive nipples. That's no good. If we use more than 8 units of GH, it doesn't generate more IGF-1. You get 450 IGF-1 at 8 units of GH, and you get like 452 at 10 units of GH. So it's just not worth it at that point. You're better off at the 8 units and save your money for other medicine.
But we can continue to increase that AOD, and that will increase the hormone-sensitive lipase effects, but only those?
My understanding is yes. I'm not an expert about that because I get my GH cheap enough that it's cheaper than AOD. So I would just use more GH in that case. But that's just me. Not other people don't have that. So in the end, there's so many other drugs you'd use, like retatrutide, SLU, PP32, clenbuterol, T3, and appropriately. I'm not saying just throw the kitchen sink at it. I have this much of an anal approach towards every medicine that we wouldn't have to resort to the frag that has no extra benefits, whereas you get extra benefits from all the other ones in addition to increased fat burning.
Right. So it's pulling the right lever for the right person.
Right. And then usually, and most of the time, the lever for them is eating their fucking diet, doing their fucking cardio. And that the people will be frustrated if they watch. It's like, Todd's my coach. Todd doesn't do any of this shit for me because they're not eating their diet and they're not doing their cardio. So until you do those two things, nothing's getting pulled. Discipline is first. You have to be an athlete. You can't just throw drugs at a problem and fix an inner problem. This is the problem. And this is the problem. You have to fix those first. Then we can amplify your perfection with these tools. And that's the difference between an intermediate and a beginner. And the I identify as a bodybuilder is that the I identify as a bodybuilder is there's someone with no discipline who just takes a ton of drugs and hopes for the best.
Well, it's always that human nature to reach towards what you perceive as the low-hanging fruit. I just got in an argument with the missus a couple hours ago, and she doesn't watch this, so I can say it, because she came into the office. I have 4 or 5 bottles of SLU sitting on one of my bookshelves over here. She's like, hey, when can I start taking this? I'm like, when you progress through your training program. And she got mad and stormed out, as they tend to do. But still, it's the low-hanging fruit. What can I add into this situation to progress me towards my goals? Well, it might not be time for that lever yet. So it's all about the right lever at the right time. So we've established this GH synergy with the testosterone, synergy with the estradiol. And let's say we still want to build upon this course because the person's the right candidate to.
Right.
We're not adding an insulin. So what direction are we going from here and why?
Right. So we're 56 minutes in and we're getting to the original question, which is, how do I use anabolic steroids, right? So now that we've done the HRT thing and people are like, holy shit, HRT is much more complicated than I thought it was. I do it different. I like to say I do it the right way and everyone else does it the wrong way. The only person, I learned this from John Jewett. I've never heard anybody else do it this way except for John. That, in my opinion, this is the right way of doing it. And that everybody who's an HRT clinic, they should be forced at gunpoint to do it the right way. At least for a while to see how effective it is. And then if they want to go back to their fiddle fuck way of doing it before, fine. But at least do it the right way first, is daily injections. And a lot of people don't understand how simple this is. You take an insulin syringe. Do you mind if I hold up an insulin syringe? Okay. You take an insulin syringe. You load it up to here for 20 milligrams a test. You load it up to here for 40 milligrams a test, whatever you're doing. Then you stick it in the GH and you load it up to here for your 2 units of GH. You pull it up to here for 4 units of GH. You stick it in your shoulder, you push the plunger down, you throw it in the sharps container. That's how simple it is. Everyone fucks it up. What size needle do I use? I like to backload. It's like, dude, I have some really inappropriate joke, but I know that your audience is probably not as callous as mine. But
go for it. You're good.
It's like, do you like to be backloaded? And they'll be like, no. I was like, do you like to get filled up from the rear? They're like, no. I'm like, why do you do it to your needles if you don't do it to yourself? And usually they don't see the correlation because obviously it doesn't make you gay. But most men are so simple. It's an easy way that every time they do this, every time they're like this, they think, oh, I just pull my pants down. So then they stop doing it.
That'll be the biggest take home. That's the biggest take home of this whole podcast.
That's your reel right there. That's your reel. It's like, that's you taking your pants down, you backloading POS. All right. So that'll be the reel. So
perfect.
I'll get clipped. It's like, what would that make me? It's like, this homophobic doctor encouraging the use of steroids is saying people who backload are homosexuals. News at 11.
But everybody got way more jacked because they started doing it the right way, so it worked. So
yeah, right. So where we go with this? So Yeah, I just want to clarify. I don't have a problem with homosexuals. If you like being backloaded, that's great. Backload yourself. Don't backload the syringe. All right.
Perfect.
So from there, step 2, this is the second level. This is intermediates only. This is bodybuilders only. If you cross this line, it is not HRT. It is not TRT. You're a steroid user. Not abuser yet, but you are a user. I believe, based off of empirical data from countless case studies, the cleanest, safest anabolic someone can use with the least amount of unwanted effects is Masteron, not Primo. The simple answer is Primo, like EQ, has a double bond between carbons 1 and 2, and Primo, like EQ, converts into an aromatase inhibitor. So after we went through all that fucking nightmare of finding the perfect dose of estrogen with blood work every month for what could have taken 6 months to find the right dose, you're going to fuck it all up by putting an aromatase inhibitor in. And so if you just use Masteron, you won't lower the estrogen level. Now, the counter argument are people going to say, yeah, but Masteron works like a SERM. Masteron does not bind competitively to estrogen alpha or beta. So if it is a SERM, it's an allosteric inhibitor that binds to a different part of the estrogen alpha receptor and causes a conformational change so that its estrogen binding site is deformed and estrogen can't dock. Furthermore, Masteron does not lower IGF-1, which would imply that it is just an estrogen receptor alpha allosteric inhibitor, not beta. So that means we get to cut down on the feminizing effect of estrogen, but not cut down on the anabolic effect of estrogen. This is another reason why I think Masteron's so great. Furthermore, if you buy into the theory that SHBG is bad because everybody's using Proviron on PrEP to mop up the SHBG, Masteron is the next best thing to Proviron for mopping up SHBG. So if you use Primo, you're still going to have to use Proviron. So if you're using Primo because you're trying to avoid androgenizing effects, you think that Primo is not as androgenic as Masteron, you still have to use Proviron with Primo, which is Proviron is straight DHT. So it is much more androgenic than Primo. So in the end, you'd have to use more testosterone to cancel out the anti-estrogen effect of the Primo, which means you'd have more DHT, because if you take a testosterone molecule that can convert into estrogen or into DHT and you plug the hole that has it leaking into estrogen, means twice as much is going to go out the hole that turns into DHT. So you're going to have more DHT. So although Primo in isolation is going to be less androgenic than Masteron, in practice, it's going to be way more androgenic. So if you're avoiding Masteron to avoid hair loss, using Primo and more test, which means more DHT, and Proviron to mop up SHBG is going to result in much more hair loss. That's why I refer to them as bald priests, the premagogues, is all the guys who push Primo are bald. Now, that doesn't mean you can't lose some hair with Masteron. If you have a lot of SHBG, it's going to mop up a lot of DHT. So then if you take Masteron, the Masteron's going to bind to the SHBG and bump off the DHT. So you're going to have a very short window where there's a flood of DHT into your body, and you're going to have short-term hair shedding. So what happens is people who are on a ton of test and have a lot of SHBG, which is atypical, usually if they're using test prop and mass prop, and they're doing it every other day, this is when they're going to still have high levels of SHBG and a super high DHT conversion. And that super high DHT conversion from prop is going to then bind to the SHBG, and then the super high spike of Masteron is going to cause a flood of DHT to come off, and that's when they're going to start having hair shedding.
Is there ever a case for these short esters, or should we just be doing long esters dosed more frequently?
Every single person be using long esters every day. I don't understand why these fucking morons are still using short esters. I can understand why a competitive bodybuilder believes you use short esters going into preps, you can make adjustments quickly. But if you actually graph it on steroidplotter.com, you'll see how ugly the graph looks when you use Prope. Prope is garbage. And then this whole idea you're going to pull the injectables and push in a bunch of orals, and that's going to make you harder and drier, is all based on the premise that the orals are all DHT derivatives and don't aromatize. But if you've appropriately balanced your estrogen going into the show, like for instance, if you just drop testosterone, you have no substrate for estrogen. So there's no reason why you would have to use orals. So for years and years and years, like 14 years, I just injected all the way up to Friday night with long esters daily. And then I got my paint done. And then I'm using orals the day of the show, Saturday. But the one time I tried to use orals instead, I blew up like a water balloon, even though it was Winstrol, because it was liver failure. And then the result was diabetes. So it's like, I totally disagree with this whole bullshit approach of using short esters for the last month, pulling the short esters, putting in orals with your carb loading, because you're going to fuck up your liver and your digestion with the carb loading. Then you're not going to absorb anything. And I know that there are a lot of the top guys do it, because I just had some people doing the Detroit Pro who talked to me about what they were doing. And they're still doing the same shit they were doing 30 years ago. So I don't know why. Maybe there's something I'm missing. But on paper and in my personal experience, it makes more sense to use long esters all year, even through the show.
Well, in terms of speaking to the masses as opposed to the individual, just because somebody has the genetics to have an iron liver that can survive a mega dose of orals with no digestive repercussions doesn't mean that the majority of people are going to suffer some sort of issue with their carb up, their assimilation of nutrients, their glucose, their glucagon. There's a lot of stuff that can go wrong. So I totally agree with that. And the short esters thing, to me, that's something that can just only be more problematic than it can be beneficial if you look at how these things are working.
My best looks were I used Winstrol 50 milligrams near the very end, and I would throw in a little bit of Halo at the end too. But that was like, we're talking 3-4 days. Like that's it. It's not like I was doing anything crazy. So, and that's just because that's what people did and it's supposed to help. And I didn't see it hurting. But insofar as if I was to do the most conservative approach, then I would, if I look great 2 weeks out and I wish I could step on stage right now. I look that good when I woke up in the morning, let's say 2 weeks out. I wouldn't change a fucking thing. Even carbing up could make you look worse. If you're going to carb up, you would do a slow carb up, and you do a diet break, a slow carb up, like maybe 5% increased calories every day until you find the perfect look. And when you spill over, go back a little bit. And that way you've had time to recover. Same thing with you pull back on volume and cardio a little bit so you can let some fatigue wash off. But why you would change your drugs doesn't make any sense, because if you already look perfect, changing anything could only be less perfect. If this is a curve and you're at the peak of the curve, you can't go more over. It's just going to make you go back down. It doesn't make any sense.
People just tend to do things, I think, because it's almost like you said, there are things that people do, so other people do them. Now, if it makes sense and you can look at it and like you did and say, okay, this isn't going to hurt anything, I might as well try it. All right, cool, roll tide. But if it's an entire change in the protocol, especially when you're saying if everything's looking great, again, if it ain't broke, don't fix it. Continue to move forward, make the small manipulations that you need to make, and then go in from there. Now, in adjusting this course as we have been doing, the one thing that I find really interesting here is the Masteron Primo debate, because everybody will fight that till the cows come home due to personal experience. But what you're doing is you're backing this on how these things actually work and how they actually do convert and how they actually bind to the receptor. And I believe that has to do, and correct me if I'm wrong, but primobolan is more structurally similar to equipoise, and that's where that theory of that receptor attenuation comes from. So when you're putting any of those in, you would have to raise testosterone in order to keep that delicate balance of estradiol that you have. So it's not that you can't use these things, it's that you can't use them without upsetting the balance that you've already predetermined, and now you're throwing away your entire approach. So are you always going Masteron like 9 out of 10 times?
No.
Or how would you choose that?
If they're already bald. If they're already bald, fuck it. Just use a 5-to-4 approach of test and primo, or a 5-to-3 approach of test and EQ if they want to save 83% of their money. And I'll just titrate them up until we hit estrogen levels that are too high. And then if it's too high, I just go to a higher increment, like 5-to-5 and 5-to-4. And then I just would right out the gate, just drive up their GH at a certain rate. And then once we found a point at which their IGF-1 saturated, they can't generate any more IGF-1 from the GH. It's almost always between 6 and 10. Then we just stop with the GH. I wouldn't even try anything fancy with them because they've already lost their hair.
Gotcha. Now, when are you making the decision to pull the trigger on that 19 NOR column? Because then you're introducing potential raises in prolactin and estradiol in and of itself from that. When is the right decision? When is the right time to pull the trigger on an NPP, a nandrolone, and then when do we pull the trigger on tren if we're doing that?
Let me ask you this. How many hostage rescue teams have frag grenades?
I'm unaware.
I don't think any of them do. They might have stun grenades, but they don't have frag grenades. Because how are you going to rescue the hostage if you blow the room up that the hostage is in?
Touche.
Yeah, like the grenades just kill indiscriminately. So if our goal is to grow muscle without hurting anything else, then a nandrolone is never an option. Like nandrolone, trenbolone is used in cows before they kill the cow. They don't give a fuck if the cow lives, or if the cow's getting insomnia, or if the cow has health consequences. They're going to chop up the cow and use its meat. So nandrolone is going to almost always cause gyno or some other problem. It's like a grenade, but in a bouncy ball. You don't know where the fuck it's going to hit, but it's going to hit something you don't want it to. Whether some people get anxiety, some people lose sleep, some people have gyno. Here's the mechanisms, because people are like, oh, he's just talking bro science. Here you go. Ready? If it's going to be a partial agonist to progesterone, sometimes partial agonists are reverse agonists. So there's two progesterone receptors, one's positive, one's negative. But remember, a positive progesterone response, a progesterone agonist at progesterone receptor, I believe it is B, causes inhibition to estrogen receptor alpha, which means that if something's an inhibitor or a partial agonist, it binds to progesterone receptor B, but doesn't stimulate it. That means you're getting less stimulation than you would from existing circulating progesterone, which means that progesterone receptor A is going to be over amplified, and that's going to drive up activation of estrogen receptor alpha. So I believe that nandrolone has a pro-estrogenic effect, but similar to how masteron, it alters the expression or the activity of the estrogen alpha receptor. So nandrolone, you could have 20 estrogen and use nandrolone and get gyno, or you could have 60 estrogen and no nandrolone and not have gyno. Just like the contrary, you could have a 30 estrogen and have no masteron and have gyno. But if you're on masteron, you could have 50, 60 estrogen and not have gyno. So I look at nandrolone as the anti-masteron. That nandrolone's great if your goal is to get bigger boobs. And nandrolone would make sense in a woman. Now, that doesn't mean I've ever given it to a woman, but on paper, it makes sense in a woman. The other thing is, nandrolone is almost anti-androgenic because it converts to DHN, whereas masteron does not convert into DHT because it's already been 5-alpha reduced. That nandrolone is extremely strong binder of the androgen receptor, so it's actually more anabolic than testosterone. If you only look at the molecule, you don't look at the big picture. Whereas technically, masteron's not as strong as testosterone because all DHT molecules will get broken down by 3-alpha HSD inside the cytoplasm before it can bind to the androgen receptor. That's to prevent DHT from causing people excessive muscle, because DHT is so much stronger than testosterone in the non-genomic tissues that to prevent it from working inside the cell on the nucleus and creating an excessive amount of muscle, there's an enzyme that breaks DHT down. So the DHT derivatives, which Primo does not belong in that class. Primo belongs in a class with EQ because it doesn't have this one modification. All the DHT derivatives have a 2-carbon, basically carbon number 2, the carbon adjacent to the ketone group that makes it testosterone, not estradiol. That carbon, if you put something on there, like a methyl group, like in the case of Masteron, turn it into an oxygen like Anavar, put an ethylene group like in anadrol, and it's also a methyl group in Superdrol, because Superdrol is basically the same thing as Masteron, but with its oral Masteron. That 2' carbon is going to create enough steric hindrance so that the enzyme aromatase can't bind and convert testosterone into wait, I'm wrong. That the double bonded carbon 4 is what prevents aromatase from converting into estrogen. That the 2' modification prevents the 3-alpha HSD inside the cell from breaking down the compound. So when you have a 5-alpha reduced testosterone, you have DHT. DHT gets broken down by a 3-alpha HSD inside the cell, and then it's no longer anabolic. It can't bind to the androgen receptor. By having that 2' modification in the DHT derivative class, then it can bind to that androgen receptor, and it can be anabolic. But it still gets broken down a little bit. Now, Proviron does not have that 2' modification. Proviron gets broken down, and thus Proviron isn't anabolic. Mm-hmm. Primo does not have that 2' modification. EQ does not, DHB does not have that 2' modification. But what makes them special is there's a double bond between 1 and 2. So technically there is still a change at carbon 2 because there's a double bond there. It's an internal double bond. It's not an extra functional group sticking out of the molecule, but it is a stabilized A ring. And so it can't get broken down either. That's why I believe Primo does not belong in the DHT derivative class. It belongs in the EQ class. Because structurally has nothing in common with the DHT derivatives. It is much more similar to EQ. So where I was going with this was Masteron, unlike DECA, is not as strong as an anabolic because some of it is going to be broken down. Now, you can saturate that enzyme. If you use enough Masteron, that there's only so much of that enzyme there, it's going to basically be irrelevant. And since Masteron, you can use almost 5-10 times as much as DECA without running into any side effects, the efficacy of using Masteron is higher than the efficacy of using Nandrolone, even if the potency is less. So let me break it down a little bit simpler. Let's say that the potency of Nandrolone is 110% of testosterone, so that 200 Nandrolone builds as much muscle as 220 testosterone. And let's say Masteron has a potency of 70% of testosterone, so that 200 Masteron is only as strong as 140 testosterone. So most people are like, well, I'd rather use the DECA because 220 is higher than 140. It's 150%. But if you use more than 30 or 40 milligrams a day of Nandrolone, you're probably going to get gyno. Whereas you could use 100 milligrams a day, no problem with Masteron, and have no problems. So that now that we're using 700 times 0.7, we have the equivalent of 500 testosterone. Whereas with the Nandrolone, if you're using 280 and 10% more, that's going to be 300. So now the efficacy of Masteron is 140% of that of the Nandrolone, because you can get away with using 3 or 4 times as much Masteron without side effects. Whereas if you used even that much Nandrolone, you will get a side effect. Now, rather than either or, why wouldn't you add them together? And my answer is you could use small amounts of nandrolone to leverage it for the anti-cortisol effect, because the cortisol causes muscle to break down and it also increases collagen synthesis. However, all of the anabolics have the 11 beta hydroxylase enzyme deactivated. So they're all going to stop cortisol from being formed at some point. They all have type 1 collagen's upregulation. So they're all going to be good for collagen synthesis. So using enough test and masteron, the two benefits you're looking for from DECA, other than anabolism, which is anti-cortisol and pro-collagen, you get those anyway.
So with the masteron, what you have is the ability to bring your total anabolic load higher, because the threshold for side effects is set much higher than it would be with the nandrolone. So thereby, since I can just take more of this with less side effects and get a better effect than less of this with more side effects, then that makes complete sense to go the masteron route every time. Right. Now, you did mention that a nandrolone will have some special qualities, as they all do. I mean, everything kind of does everything, but we know that each of these specialty drugs will have a slight tilt in one direction or the other. You did mention that nandrolone does have that propensity to lower cortisol, but as does testosterone in a higher amount. Is there ever a use case to add in a small dose of nandrolone then, or is it always better just to go higher on the other two?
No. That I basically just did a video called Advanced Cycle. And I say, like, this is literally putting a loaded gun on the table in a kindergarten and saying, don't shoot yourself, kids. And I know you're going to shoot yourself. And then you're going to need to get a consult and have me fix it.
That's your Infinity Gauntlet one, right?
Right. My Infinity Gauntlet of anabolics. Awesome. If you were going to make a stack, using these 6 is the perfect stack. But you still don't need to do it. But if you did it, the right way to do it is to balance EQ with test, to balance masteron with nandrolone, so that you can leverage a total amount of 30 milligrams a day of the EQ and the nandrolone to get to the 200 milligrams a week to optimize collagen synthesis, while still having less than 10 milligrams of nandrolone, so you don't get the cortisol inhibition in the brain, because we want cortisol in the brain so that we can have refreshing of the tissue. If you over time keep blocking anti-inflammatory in the brain, you'll get brain inflammation, and it's brain damage. It's not a lot of brain damage at 10 milligrams, but there is some brain damage as opposed to like 7 milligrams. So if you were going to add in nandrolone, the safe dose is like 7 milligrams a day. So no one's going to do that. So then it might as well just not use it. But I said, right, in hypothetical terms, if you already don't have hair, then you could use EQ with a baby dose of nandrolone and get slightly better effect than just using test and masteron alone.
What we're looking at essentially is, on paper, we have these effects of these compounds that, based on mechanisms of action, can do all these wildly beneficial things. But in speaking to this more intermediate audience, somebody that's, been around the block a few times, but they're not a top pro or anything like that, what we can take away is, if built up and titrated up correctly using the right amount of synergy, more people than not can benefit from leveraging testosterone and growth hormone, then adding in a masteron from there, completely ignoring the insulin route because it's only going to cause problems, and then potentially leveraging your equipoise or your primo in a situation where they're not concerned about hair loss from that aspect. But we're probably better off looking into that masteron. Before we wrap things up, is there any reasonable application now, just in the pursuit of hypertrophy, getting bigger, performance in the gym, not talking about the last few days before a show, is there any reasonable application, in your opinion, for any sort of orals?
Not really. The only time I would say yes is sublingual Anavar with DMSO. So if you're going to, or brush your teeth really hard, make your gums almost bleed, and then squirt some liquid Anavar against the gums. That way we get to bypass, skip the liver, and then if you're immediately lifting, it goes right to the muscles. Supposedly, it can increase strength and aggression. I've seen it both ways. I've used it and it did, and I've used it and it didn't. And that you might get an increased performance. again, lifting more load generates more fatigue. And then the more fatigue you're accumulating, whether it's through food fatigue, training fatigue, or drug fatigue, the more fatigue in your body, the more inflammation, the less efficient your body is going to be at processing the drugs, the food, and growing more muscle. So you're robbing Peter to pay Paul. Basically, you're getting a very short-term benefit for long-term consequences, just like insulin. Insulin will help you grow for a couple weeks, and then now you're insulin resistant, and now you're going to need to have months to repair the insulin resistance. It's like the same thing as, unless you're getting IV glutathione, I don't think even using Anavar sublingually in the off season is worth it, because you have to repair the liver damage as you go, adding liver damage.
It's just crazy because everybody seems to be overcomplicating something that's already incredibly complicated, yet they're not grasping how complicated it really is, and they're overcomplicating it in the wrong way, and they're causing problems that shouldn't even be problems. These shouldn't even be bridges that people are crossing. So it's just insane. It's funny to look at it as, you need to take a simplified approach, but in order to take the right simplified approach, you need to understand something that's incredibly over your head in most cases, which is the reason to hire a good coach. Todd, this has been amazing, and this has been a much deeper dive than even I expected, in just that, in a way to look at things simplistically, but through an incredibly advanced lens. If people want to absorb more of this information, where can we find you? Where can we reach out to you for coaching? Where can we watch your content?
So the easiest thing to do is I use the handle Todd Lee MD because it's my name. So if it's Instagram is the easiest way, because that's my primary platform is Instagram. I have a YouTube channel, Dr. Todd Lee's Anabolic University, which sounds like a mouthful, but if you just Google Todd Lee MD or Dr. Todd Lee on YouTube, you'll get to me, right? ToddLeeMD.com. Again, it's just my name. So I try to make it, everyone's got these funny names on Instagram that are kind of hard to remember. I just use my name, and I've had my name a long time. So I basically have used it since the beginning, since Instagram ever started. I've been using the same handle. So just get a hold of me that way. Follow me on Instagram. I don't like that term. Subscribe on YouTube. And remember, the YouTube videos are the real videos. On Instagram, those are clips of a full-length video. I'm not making a 90-second reel just to make you mad. That the 90-second reel was taken out of a 55-minute presentation, and it is not going to cover all the outliers and nuance. It's not intended to offend you, because I'm not specifically addressing your personal truth. It's that this is a generalized 90-second clip that's like a preview. Like, people get pissed about a reel. It's like they watched a preview for a movie, like Blade 4. They're like, Blade 4 sucks. It's like, you saw it? No, I saw the preview. It's like, well, motherfucker, you didn't watch the movie. You watched the preview. Wesley Snipes didn't cut up the preview. It's like, he's not responsible for the preview. That the preview is made by the studio and the marketing department. So,
you know what? The people that get mad at that are probably the people that like to get backloaded. Not that there's anything wrong with that.
Get backloaded. Dude, that needs to be a shirt, is get backloaded. And it just shows like a little syringe bent over and a big syringe going right up its backside.
If you don't do it the next 6 months, I will. I promise you that.
That would be awesome. That would be an awesome shirt. Get backloaded. It's like
this
prison
is the best
style.
send off to any show that I've ever done. This is spectacular.
If you don't like my reels, get backloaded, bitches. There you go.
Perfect. Todd, thank you so much, man. We'd love to have you back at some point to deep dive into some more topics.
I would love it. I love your channel. I love the guests. It's such an honor to be amongst the luminaries of the training community, because I love the exercise physiology content. I love that way more than I love the steroid content, but there's less people like me than there are people like that. So I might as well just stay in my lane.
Dude, the honor was all ours. Thank you so much again, and we'll catch you next time on the DDT Method podcast.